fine. I feel like I've seen you guys every Monday and Friday. Do you all really test anymore besides my film? Yeah? Okay. You got a couple left? Did you say next Friday? Like this Friday? I was like, next Friday? Holy crud.
Friday, Monday, Friday.
Okay, so they're coming. Yeah, we get to see each other like bright and early every day this week, except for Friday, I think, after your exam. I'm still first class, so yay. So I'm a little slower than driving, that's fine. Like you say, 8 a.m. lectures. Okay, what's Friday? What test? Eyes? Okay. So that's what you looked at all weekend. So then I'll still ask. Any questions from the first lecture from last week? Anybody actually? No? Yeah, okay. Yeah. It was all chest and not eyes. Okay, so that makes sense. Cool. You will use like 10 eye things in your practice. That's about it. But the pants has it, so you gotta know it. Cute eye, that's what you need to know. All right, so we'll jump in. So, yes, lecture slide 2. Oh my goodness, only 58 slides, right? It's thick, guys, okay? So we're gonna go slow. I do not plan to go into lecture 3. If we happen to finish a little bit early, then yay, we will, and we'll just call it good. Because again, I do have that one extra block already put in there for other lectures if we get a little behind or go a little slower. So I do not plan to go into lecture 3 today, but we're going to jump into this. All right. What's going on here? Yeah, right? It looks like they're stabbed. Do we know just based off of this image? No. Could this knife just be laying on their chest? Yes, it could. This is why 2 different pictures are important, orthogonal views, right? This could just be somebody, you know, I mean, obviously it's inpatient. We got this giant, not necessarily a tube. What do we think this is? EKG lead. Yep, that's the wire to the EKG. Can't get those out of the way sometimes. They try to move them out of the way, but sometimes they fall back into place. Not a whole lot we're doing there. But yes, this patient is likely stabbed, but can't tell just by the image. What are we going to cover today? Heart and great vessels and some airway stuff. Kind of what we covered a little bit last time, but really everything last time was knowing the normal, knowing the anatomy. We're going to get into some pathophysiology today. We're going to start finding some abnormalities. We're going to start looking at things, and at first you're going to be like, I don't see it. I'm going to take my time, try to break it down on a surface level of pathophys of why is it happening? Because again, I fully believe that if you understand why it's happening, then you can think yourself through what's going on in the body, then you can be like, this is what I should see on the image if I understand what's going on in the body. Surface level, not getting super deep in the pathophys, we'll save that for cardiology, save that for pulmonology. From a disease process, I'm going to give you enough to arm you with enough knowledge to be able to interpret the films with the patient vignette, to be able to sort through different things, okay? So keep the questions coming like you guys did last block. Just know that if you start to get too deep into like the pathophys questions, that'll be next semester. I'm gonna kind of tell you, some of you have already heard me say it. I'm gonna tell you lily pads, right? Stay on the lily pads for this course. Don't get in the swamp. Don't let the stems and the roots of those lily pads drag you under, all right? We're gonna give you enough to understand the images, and then we'll let Dr. DeBoer, and Dr. Cola kind of do the pulm and the cardio stuff and get deeper next semester, all right? So the 3 main things we're going to cover in this first part is going to be cardiomegaly, which means what? Big heart, enlarged heart, right? So we're going to talk about how at a quick glance can we look at this and say, is this cardiomegaly or not, okay? We're going to look at congestive heart failure. Key thing with congestive heart failure, this is an end-state disease, okay? A lot of things we're going to talk about after CHF, okay, is going to be things that will eventually lead to this, but I start with congestive heart failure so you can see what that looks like, and then we'll go a little bit more surface after that, understanding that a lot of the other disorders we're going to talk about can and will lead to congestive heart failure if they are let left untreated or gotten worse over time. All right, and then finally pneumopericardium. Let's break that down. What do you think that means? So we got pericardium, right? Pneumo. Anybody? Say again? Air. Air in the pericardium. Yes, we can see that on X-ray. Yes, that can happen. We can have air within our pericardium. So we're going to break that down. All right. So what is cardiomegaly? We briefly discussed it last week. We'll say it again because I know you guys are knee-deep in the eye, right? When we're looking at the PA view, and this we don't have AP on there, PA, right? In general, if the heart is more than 50% of the width of the thorax, that's considered cardiomegaly. That's from the edge of that right atrium to the edge of that left ventricle. I don't need you to measure it. We're eyeballing this, okay? We're just going to eyeball it and kind of look at it. So no, you don't got to get hung up with and I'm making up measurements here. If the thorax is, 15 inches in width, is that heart 7.6? 7 point, guys, don't worry about that. I'm not trying to trick you on things, right? That's not the idea here. This is just, do you notice it? Cardiomegaly is a finding, right? Cardiomegaly is usually happening because something else is going on. There's some other kind of disease process happening. So what this is this is a finding to lead you to go, what's causing this? Because the heart doesn't enlarge just because it wants to. Something else is causing it. So this is one of those findings where you start with that and go, I know that's abnormal. Let me look at the rest and then kind of look deeper into the patient to see what could be causing the cardiomegaly. Okay. On the lateral, we'll look at this. We haven't talked about it very much, but the cardiac shadow is going to encroach and overlap that spine. For those of you that may have looked at it, you notice a lot of our lateral chest x-rays last week. The heart didn't really go over the spine. There was that nice little space between the back of the heart and the spine. What do we call that? Remember? Retrocardiac, behind the heart, the retrocardiac space, a little bit darker than the surrounding tissue, right? So in cardiomegaly sometimes, that retrocardiac space isn't there. Why? Because by the time we get to behind the heart, it's the spine. So it's really, it doesn't have that chance to have that darker kind of window. We'll look at some of those. These are just your three main causes, right, of the heart enlargement. Pericardial effusion, which means it's not really heart enlargement because there's fluid in the pericardium, but we know that fluid and soft tissue look the same on X-ray and CT. Extracardiac factors, okay, great. Anything involving not the heart. And cardiomegaly, which is true cardiac enlargement. So basically, what can cause the heart to be enlarged? Fluid in the pericardium, the heart actually being enlarged from hypertension and things like that, like left ventricular hypertrophy, and anything not involving the heart. So you see how it's not very beneficial to just go, oh, they have cardiomegaly. Now you have to look deeper to try to figure out why. You'll learn a lot more of that in your next semester. Okay. So let's focus on the not the true large heart, right? The pericardial effusion. A lot of words on this slide. This is a really important slide to help you kind of understand why it could look like an enlarged heart. So first of all, fluid knowing on CT. So you don't need CT necessarily, but it can kind of help break down and see some of that fluid around the pericardium. The biggest thing is understanding where things start and kind of where they go. So it initially fills from the left side. Why do we think it's the left side? It's kind of how the heart lies, right? That left side is going to be a little bit more kind of inferior, so fluid gravity pulls it down. So it fills the left side first, then it goes to the right side, and then it fully encircles the heart. So understand how the heart sits and where that pericardium kind of lies, all right? What can cause it? Guys, look at that list. Okay. We are not covering all these things. You will before you graduate, right? We are not covering all these things, which means if I give you an enlarged heart on the exam for some reason, right, I need to give you a heck of a lot more to try to figure out what the cause was, right? I can't just give you an x-ray of a left ventricle and literally the question just be a large left ventricle or a large heart and just say, what caused this? You gotta have a vignette, right? You gotta have the information to come up with, not definitive in this case, a most likely diagnosis, okay? That's where I want you to get, especially in this block, to start thinking. and it'll prep you for your junior semester, for your cardio, for your pulm, for your ID, for your endo, for all that stuff, is start thinking most likely. Because what's going to happen is you're going to have a couple that it probably could be, but one is the most likely, and that's medicine in a nutshell. You're telling the patient, hey, I think it's this, because of the information I have in front of me. It could be something else. But we'll deal with that if you don't get better after I treat you for this, and you come back, then we'll start looking at some of those other things, right? So, yes, you can use ultrasound to identify pericardial effusions. CT is a little bit better because you can get that fine detail, so you can see the really small ones that start around the left ventricle. Why don't we use plain films, or why is it not a good choice? Because again, we already talked about it, fluid, soft tissue looks the same. You can't tell where that pericardium starts and that heart begins, and the difference between the two when you're just looking at an x-ray. What are those extra cardiac factors that can cause the heart to look enlarged? Well, the first thing, the AP. Knowing you're looking at an AP. Because if you have an AP chest x-ray, it's not necessarily abnormal for the heart to be a little bit larger than 50% of the thorax width. So if I give that to you, tell you the AP, then you should be thinking like, okay, I should expect to see that. Again, I don't have a whole lot of AP chest x-rays on the exam. Really the only time they're going to be on there are the conditions where patients are hospitalized, because that's the only way for them to get the x-ray. But it will tell you it's an AP, and the odds are, I'm trying to think, in the past year and a half, I don't think I have any questions that when there's an AP chest x-ray are reliant on you telling me whether or not it's cardiomegaly. It's more disease process type stuff, because I don't want you to have to sort through that at this stage. We talked about suboptimal inspiration, right? How that diaphragm can push out up if they haven't taken a deep enough breath in and cause the heart to kind of smush a little bit from the pressure, which then makes it kind of go out a little bit. That's going to make it look enlarged. So when I see something that's cardiomegaly, one of the very first things I'm doing that I probably should have done in the beginning, but sometimes we get excited, we want to look at the image and kind of figure out what's going on. If I see an enlarged heart, I'm counting those posterior ribs. Because if I don't have at least 8 posterior ribs on that chest x-ray, then I'm starting to think that it's suboptimal inspiration that's causing the enlarged heart. And until I get an x-ray that has at least 8 posterior ribs, I can't call this cardiomegaly. I can't, okay? Obesity, pregnancy, ascites. Pathophys behind that, the same as the diaphragm, right? A lot of pressure pushing up from the abdominal region, whether it's fluid for the ascites, whether it's baby and uterus pushing up, right? Obesity, lots of subcutaneous tissue and fat can be pushing up. That can cause what looks like cardiomegaly, all right, when really the heart is actually fine. So having that kind of in the back of your mind. Chest wall abnormalities. Anybody know what pectus excavatum is? We talk about it? Yeah, right? My son has this, right? The ribs kind of come in and point in. There's different levels of severity. Depending how severe it is, it can press on that heart, causing it again to kind of bulge out the sides, making it look enlarged. The good news is a lot of these people that are that severe, a lot of times will end up getting a surgery shortly after puberty to try to fix it, because it will cause significant problems going forward with that consistent pressure on the heart and the lungs. But pectus excavatum. Rotation, we talked about that one, right? So if they're rotated to one side or the other, the left ventricle could project bigger, the right atrium could project bigger, making it look more enlarged. Luckily, we have a tool to figure out if the image is rotated, and where are we looking for that? Okay. Spinous processes and clavicles with the sternum. Right, look at that, look to see if it's rotated. If they're right down the center, and those clavicles are going right to the sternum, then we don't have rotation. That's probably not the cause. One step to kind of piece together to make sure this is real cardiomegaly or not. And then finally, yet again, the pericardial effusion. But this one is a pericardial effusion caused by things that are not heart related. Lots of things that cause a pericardial effusion. Nothing to more, we'll get more into it. This is normal. All right, here's your PA chest x-ray. This is normal. Again, you see what I say when I say eyeball it, right? Eyeball it. It's not exact measurements, but you can usually tell just from looking at it when you kind of measure it out that, yeah, it's about half the width, right? So it's a gross estimate if it's borderline and you think it's going to make a difference in your diagnosis and it's going to make a difference in your treatment, you can evaluate further to figure out what that is. Sometimes it's a CT, sometimes it's other testing, but for us, cardiomegaly is going to be based off of, is it about less than half the chest width on X-ray, on a PA. Now we put the normal with the cardiomegaly. Do we see the difference? Right? You're sitting there going on this, you're like, I know tap, I'm not really sure. Put these two together, right? Heart border, here and here. Definitely more than half. Here and here. And the nice part about enlarged hearts, it almost kind of looks like a kind of smushed water balloon a little bit too, right? But before I say that's cardiomegaly, what do I got to do? I got to go through and I got to count my posterior ribs for sure. So I got 1, 2, so 2 comes up in here, so 3, 4, 5, 6, 7. I can stop at 8 because I know it's adequate, right? So again, tracing my anterior down, 1, 2, now bringing 2 back up. See how 1 and 2 are like superimposed up here, right? Which is why I do the 1 and the 2 and then come up. 3, 4, 5, 6, 7, 8. I can stop counting. We have adequate inspiration. If I look at my spinous processes and my clavicles in with my sternum, I don't have any rotation, okay? This patient is not, we'll just say, they're not pregnant, right? They're not obese. I don't have anything else that would suggest that the cardiomegaly is being caused by an extra cardiac factor or a rotational issue with the image, so we would call this cardiomegaly. Just your kind of quick, hey, this looks big, let me run through my ribs, let me run through my sternum, let me take a look and just make sure there's nothing else that could cause this to be looking enlarged. Yeah, go for it.
Is it the angle of the X-ray? It looks like the clavicles are like elevated on the cardiomegaly.
Yeah, so here's what he's pointing out. So is it the angle of the X-ray? So what he's saying is, here's my normal. See my clavicles are nice and horizontal? He says that these are slightly kind of angled, okay? Kind of angled up. It's likely the tube and the projection, all right? So we could have a couple of things. One, this patient could just be rolling forward on the normal, right? So the clavicles are good. The other one, maybe they're reaching up instead, so kind of bringing those clavicles up. So there's different positions they could be in. Right. Yeah, good catch, right? Something that's different from what we've been looking at. Here's the picture of the lateral, right? So we still kind of have a little bit of our retrocardiac space, but do you see here how the back part of the heart is starting to infringe on the spine on both sides? Also, something else we're noticing is, here's my normal. Remember how I said the thoracic vertebrae go from bright to darker as we go down? That's not really happening. I mean, a little bit down here, but all of these guys kind of here in the center, they all look very similar. This is, again, from the heart kind of infringing back a little bit. This is one of those spine signs we talked about. That's the general term of the vertebrae not getting darker as we go down. Now, I use this in conjunction with this, right? Some of the more severe ones, you'll see that heart coming all the way back in the vertebrae, not really just touching, right? But the idea is, see how I got this nice little black area right behind the heart on my normal, right? It's gone on my abnormal, and that spine sign is another example of these vertebrae supposed to be getting darker, but it's not really happening here. Okay? Questions on that? Everybody see what I'm trying to point out? What's the definition of cardiomegaly? 50%. Right. Anything larger than 50% of the width of the heart compared to the width of the thorax. Okay. Congestive heart failure. Final common pathway. Okay? Final common pathway. So yes, when we get into the other lectures, other conditions we talk about can and will lead to this, which is why sometimes with some of those conditions you'll ask me, hey, we'll talk about it, right? with another condition like, hey, I'm noticing this parabronchial cuffing, which we'll talk about here. Is that there too? Yes, it is, right? It's because it's a stepwise process. So some of the stuff we're kind of mentioning here, bless you, isn't necessarily just congestive heart failure. Other conditions can have these things and be leading to it. So we'll kind of get into that. But what are my symptoms? Guys, most of our conditions, we're going to have decreased exercise tolerance, dyspnea on exertion, shortness of breath. Why? Because we're in the chest. Right? Whether it's fluid, whether it's an injury, whatever it is, these are the symptoms it's going to present with. So there's not a whole lot necessarily on some of these things that are going to be generalized with the conditions, but there will be some specificities. There will be some more narrow kind of descriptors. So when I say shortness of breath or fatigue, it'll be like getting worse with like just walking around the block or things along those lines. And I'll point those out as we get to them to try to help distinguish when we go from one disorder to another, okay? But that decreased exercise tolerance, dyspnea on exertion, weight gain, fatigue, right? Left-sided orthopnea, paroxysmal nocturnal dyspnea. Lots of big words. Anybody know? Shortness of breath at night. I have difficulty breathing. What's a way a patient's not going to come in and be like, hey man, I got paroxysmal nocturnal dyspnea. It's getting really bad. What is something that they might say that would make you think that they're suffering from this? So when I lay down, it's difficult to breathe, but more often than not, they won't necessarily say that. What they will say to you is like, hey, lately over the past few weeks or the past few months or whatever, when I go to bed at night, I've either had to sleep in a recliner or I've had to use like 2 or 3 pillows to help prop me up, right? Because I have a hard time falling asleep, but then I put those pillows and it props me up a little bit, and that seems to really help, right? That's going to be your patient's statement for that paroxysmal nocturnal dyspnea. That's them telling me that when I lay down at night, I have a hard time breathing, right? It's because this is what you'll see here in a little bit. This patient is super fluid overloaded in their lungs, right? And that's why they're having a hard time breathing when they lay down, because gravity is not helping pull fluid and flow it off here. They're just laying down. A hard time. So when they put that pillow up, a little bit of gravity kind of helps in that nature. Okay. Sometimes they'll have right-sided pain, right upper quadrant pain and fullness. Lower extremity edema is a big one, right? Swelling around the ankles, swelling in the calves. That's going to be a big one too. Again, we're fluid overloaded. When we're walking around during the day, when we're just sitting up, where does that fluid go? Lowest possible place. Gravity, lower extremities. Okay. Chest x-ray is my initial study. That's often where you're going to see it first. Yes, CT and ultrasound can help define the causes, because again, congestive heart failure is a final pathway. It's a diagnosis because something else was going on that didn't get treated appropriately, so now we're at a stage where we call it congestive heart failure. So yes, you can call it congestive heart failure even though they have no disorder, because this is a diagnosis, but it's an end stage thing. What do we get? All these things are things we get with congestive heart failure. And we're going to look at almost every single one of these abnormalities. So when you get the pulmonary venous hypertension, you end up with cephalization. This is the prominent upper lobe vessels. Remember on our normal, we talked about how we can really see that pulmonary vasculature from like the bottom 2/3 because gravity, and they're a little bit thicker and it helps. We don't really see a whole lot of it in the upper area because they're smaller, and again, gravity. Well, when you get pulmonary venous hypertension, you get backup. And so those upper vessels end up with more fluid because things are backing up, so they're more prominent. That's cephalization. Prominent vessels in the upper 1/3 of the lungs, and we'll see some pictures on that. It goes along with the larger than central vessels. We talked about where the pulmonary vasculature is. Sometimes we'll see that in the heart area. Interstitial infiltrates, curly V lines we'll get to. Okay, don't hang your hat on those. They're really hard to see. I'm not going to make you pull them out, but then you'll see why, because they're very, very difficult to see. But parabronchial cuffing, we will take a look at that. We briefly talked about how, like I was prepping you guys, right? How we don't see the bronchioles on x-ray. We see the vasculature that goes with it. However, If I have fluid around those bronchioles, they stand out a little bit more because I see the fluid and then I see that lovely little black circle, right? That's parabronchial cuffing. The fluid is cuffing around the bronchioles, and so that's what we call that, and we'll take a look and see what that looks like. Fluid in the fissure, we will actually see some of those, and we'll see pleural effusions as well. Okay? Now we have our pulmonary alveolar edema, so now we've gotten fluid in the alveoli. That's going to look different than fluid in the interstitium. Because instead of just lining things up, it's going to be sitting in the alveoli. And you guys are going to take a look at that, and you're going to see what that looks like. Okay? Ultimately, we can get an echo to really try to look at it, which is a dedicated ultrasound of the heart. But this more kind of is looking for like murmurs and things like that that can be causing it. We're not going to dive into it. Dr. DeBoer will talk about echoes a little bit. You guys will almost never have to read or dictate an echo when you order it. It's typically done in a cardiology clinic with their trained ultrasound staff, and they're watching for like murmurs or leaking of the vessels and things along those lines. So I don't think you'll ever be in a position where you'll have to interpret an echocardiogram, but you'll learn when to order one and what to do with the findings. Okay, so we're not going to cover that imaging too much. Two most common causes in the United States of CHF: coronary artery disease and hypertension. Why? Because in this country, we live significantly unhealthy lives as a whole, society as a whole, right? We cause most of these things ourselves. Diet, lack of exercise, sedentary lifestyles, right? This is something we cause ourselves in this country. Which means you're going to see a lot of patients with this, especially for those of you who are practicing on the outside, guard reserve, going to family practice, you're going to see a lot of patients with this stuff. That's one of the most frustrating things in the world, because you're trying to tell them what to do, and they won't do it, and they just keep coming back and seeing you. Yeah, you'll get there. All these other things can cause CHF. Okay? I am not looking for you to recognize the arrhythmia and see that on image and then lead the CHF. I want you to be able to tell the difference between CHF versus some of these other disorders. Okay? Use a patient vignette and go, the most likely thing is going to be this. All right? Your main two radiographic patterns on X-ray are right there. This is what I want you to learn to start kind of pulling out. Pulmonary interstitial edema and pulmonary alveolar edema, and they're going to look different. And you will see how they look different as we roll through this. Here is a little bit of a picture of kind of the pathophysiology and kind of the stepwise process of things. So we start first having fluid back up into this area. It starts pooling right around the parabronchioles, right around here. You notice how in this first picture, there's not tons of fluid, okay, into the whole alveolar sac and into the alveoli yet. It just starts off with around those parabronchioles. That's the starting point. We'll look at pictures with it, but it's a stepwise process. So there's different stages to this. I don't need you to memorize the stages when we get to it. I don't care in this course if it's CHF stage 1, stage 2, stage 3, all that. That's over there too. But I need you to pull up a little thing so you know CHF is on the differential. So, and we'll see what that looks like. The fluids first starts right in here, coming out of the arteries from the overload, a little bit of seepage, and it's happening in there and covering the parabronchioles. Then we get into our alveolar. Look at all the fluid in the alveolar sac. So as you can imagine, just from a thinking about it standpoint, right? Knowing X-rays, knowing how fluid shows up on X-rays, these two things are going to look significantly different. Starts with this, leads to this. Then over time, we get an increase in heart size, not necessarily because the heart is the problem, and it may be from another underlying diagnosis, but really what's happening is the fluid is building up. So it's causing it to look like a cardiomegaly. The fluid is building up with the pleural fluid, and it's making the heart look bigger. Now, it could be because of hypertension to start that was untreated, so it is a larger heart, but we don't care about that. Because at this point, if we got the parabronchial cuffing, and we have the pulmonary alveolar edema, we're in CHF stage, right? That's what was more important, is fluid, getting the fluid out of the body, getting them on a medication like Lasix or furosemide to try to drain that fluid. That's what's more important. Severity levels. Don't need you to memorize the severity levels. But what this slide is intended to do is to show you that stepwise process. We'll get better pictures and break it down a little bit more with each step and kind of look at the things. But I want you to compare 0 to 1 to 2 to 3 and see how it's worsening as this goes on. So we have our no edema, or in this case, I would say normal x-ray for the most part, because none of the symptoms have started showing yet. We got a little bit of vascular congestion, and the reason I say that from my standpoint, okay, is look at the vessels down here. They're a little bit more prominent compared to the first x-ray. A little bit more prominent compared to the first x-ray. So I'm like, okay, we got a little vascular congestion going on here, right? I'm starting to see up here a little bit more prominent sepalization, but in reality, look at number 2. Look at how prominent the vessels are, the vasculature is in these upper lungs compared to 0 and 1, right? Again, these are small x-rays. I recognize they're small films. We'll see some other ones that have a lot better pictures of the sepalization and everything. Can't really see the parabronchial cuffing on tube. We should be able to. Small picture. We'll look at it again. And then my fluffy alveolar edema in severity level 3, this patient is really sick. I know 3 stands out way more than 1 and 2 compared to the normal, but let's go a little bit deeper onto it. So, how do I tell the difference between interstitial edema and alveolar edema? Lots of words until we get to the pictures, okay? Those 4 guys, fluid in the fissure, parabronchial cuffing, pleural effusions, and then the curly V lines, it's there. You need to know that curly V lines are a sign of CHF. Outside of knowing where they're at, like the definition when we get to it, I'm not going to make you pull out curly V lines. I'm not going to do it, because when I get to those pictures, you're going to look at me like I'm crazy when I'm pointing them out. They're very, very hard to see, and that's even on a good reader with a good chest x-ray and zooming in. So your guys' stuff, you're not going to find them, but definitely know the definition of them, and then they can be a sign of CHF. Pulmonary alveolar edema is going to be a little bit different. It's that fluffy picture. It's called a bat wing of a butterfly. We'll take a look at it and some more pleural effusions. So this is what's going to put you in between the 2 different areas of whether it's interstitial edema or alveolar edema. Let's start with the curly V lines. Get that little horizontal line right there. Yeah, right? Short, horizontal lines, just in the periphery. And if you compare it to the normal magnified right in, you're like, oh yeah, that shouldn't be there because it's not on the normal. Not on the normal, and then there it is. Usually distal 1/3, right? Okay. Know where they're supposed to be. I'm not going to make you pull those things out. But you definitely should know, where would you find them if you were looking for them? Because that is a wonderful PANCE question. What area of the chest x-ray would you be looking for if you were trying to find curly V lines? It is a wonderful PANCE question, and I know, because I just had it last quarter, which I thought was ridiculous. But hey. So, that's where you're going to see them. Let's get into stuff we actually can't see. Parabronchial cuffing. Big white arrow is the biggest one I want you to pay attention to. It's a ring-like density, right? Surrounding the bronchiole. The reason we can see it on this one and not on the normal is because there's fluid leaking out into that area, now surrounding that bronchiole. So it makes it stand out even more. The little arrows here are starting to show some more of the vasculature being a little more prominent in areas where they're not compared to the normal. Okay? But this is your parabronchial cuffing. Now, if I see this with the black in the center, it's a bronchiole. If I see a little like this right here, what's this circular thing in the center, do you think? This one right here. It's a vessel, right? Why? It's grayish. It's filled with fluid in a nice little circle, okay? The vascular in the chest can go multiple ways, and sometimes it comes straight forward. And what will happen is the x-ray will catch it to where it basically is a cross-section of that vessel, and so that's what you're looking at. You're looking at a vessel that is either sending blood either directly posteriorly or directly anteriorly, and it just happens to be the way they caught that picture. How do I tell the difference? One is light gray all on the inside. The other one has the fluid all on the outside and it's dark in the center. This is not parabronchial cuffing. This is. Does everybody see it on this x-ray and understand the pathophysiology behind the parabronchial cuffing, why that's a part of congestive heart failure, fluid overload, fluid starts leaking due to just the pressures, and then it's surrounding the parabronchial, or surrounding the bronchial.
It can happen in any of the two.
Yeah, say that again?
It can be on vessels or it can be on the
So your question is, can it be around vessels or is it just the bronchioles? Is that what you're asking? So if it was around a vessel, right, the fluid's around a vessel, I wouldn't be able to make out the center because it would all just be whitish or gray, like light grayish. So good question. Yes, the fluid can be around the vessels, but that doesn't stand out because I don't have that contrast. It's all just fluid. Go ahead, ask again. Yeah, further clarify.
We can see both of these with bronchial cuffing. Those two.
You mean this and this?
Yeah.
So yes, because this is just normal, right? So parabronchial cuffing is an issue in that area of the lung right now. So you can have a healthier part of the lung that it hasn't gotten that far yet. So you can end up seeing this vessel. Let's say the parabronchial cuffing was down here, and then this, it hadn't gotten far up yet, right? So you can have both on the x-ray. Which is why I wanted to point out how they look a little bit different and why one is the other, so you don't confuse it. And more primarily, I don't want you to confuse parabronchial cuffing for the normal, because you see the little circle thing and you get excited. That's more often than not what I see. Exam-wise, is someone will pull out, I thought that was parabronchial cuffing because there's a little circle there. That's a vessel, right? It's not dark and encompassed. But yes, you can have both on the x-ray. We good? More questions? I know this one, I told you this one's, it's thick, so we go slow. Like, I want to answer any questions you have. Fluid in the fissure, another sign of pulmonary interstitial edema. Fluid in the interstitial, right? Where's my fissure? I can't find it. I know it's in this general vicinity because I know my anatomy, so I know there's some lobes there, so I know there's a fissure there, excuse me. And now I have fluid in my fissure. How do I know that's a fissure? Well, it's anatomy-wise, I know it's right there. And it's this nice little horizontal area where the fissure kind of goes. And what happens is I have fluid leaking out, it comes down in between the lobes, and it just sits right there. So I have this nice little fluid line. Now, we're going to look at something a little bit later called atelectasis, which could look quite similar, but there are other signs that will tell you which one is which, primarily the atelectasis. But fluid in the fissure, okay? We usually can't see it unless there's fluid there. And it can be on either side. This is just showing it to you on the right side. Okay. Pretty straightforward on that one. We'll see more of them. If you have questions, let me know, but really just know that fluid comes out and sits in between the lobes. That's why we see it. Blunting of the coshaphrenic angles. So you remember we talked about last week, we have this nice little sharp angle on both sides of the x-ray. The coshaphrenic angles. They should be nice and sharp and come to a point. Okay? When they don't, there's fluid in there. That's what blunting of the angles is. What happens is some fluid is filling up in the bottoms, because why? Because gravity, and that's where fluid's going to go. And so it fills it up, and then we start to get like rounded tips. Rounded tips, and not these nice little sharp points all the way down by the edge of the thorax, right? Another sign is, yeah, maybe it still forms a sharp point. Maybe you're like, it's still kind of a sharp point. But is it up to the edge of the thorax like these ones are when you look here and you see that light gray on each side in between the lung tissue and the rib with the rounded tips, okay? Here's the catch with this one. You need at least 300 milliliters of fluid to see it on your PA chest x-ray. That's why it's important to look at both your PA and your lateral. You only need 75 milliliters to see it on the lateral. Why do I need so much to see it on my PA? Because my anterior costophrenetic angles are higher. So it's going to fill up back here first, fill up, fill up, fill up, fill up, fill up. And when it gets to 300 milliliters, that's when we start seeing it here. Whereas on your, I don't have it yet. Later on, I'll show you some lateral ones. On your laterals, you can see it as low as 75 milliliters because that's where it's going to go first. So another reason why we get the two x-rays, so we can compare the two, because you will catch the pleural effusions prior to, on the lateral, prior to the PA. Do we see the blunting on this one with the big blue arrows? Does it stand out? If not, that's okay. We're going to look at some more. But again, that's just, again, leaking fluid that's pooling down there and causing the blunting. This is all still interstitial. Now, for those of you who are looking at this and going, what's that? Yes, that is abnormal, right, compared to the other side. So what is it? It's going to be just another edema, pulmonary edema sitting in there. This person is starting to get close to the alveolar ones, and we'll see what that looks like. But if you notice this, or this one on this side, right, you should be good. You can kind of notice some of the cephalization up here a little bit starting, but it's kind of similar, so don't get too hung up on that. Here's my alveolar. So look at where we started, right? You guys who saw this here and this, you saw this and this, and I want you to kind of look also, when we talk about interstitial, look at how all the lines, right? Everything's linear, even in these little kind of clumps, they're kind of linear and following that vasculature down. When I get to the alveolar edema, it's patchy, it's fluffy. You can absolutely have fluid in the fissures as well with this because this is the next stage. So you can still have the parabronchial cuffing. You can still have some fluid in the fissures. But now I get this patchy kind of white, light grayish area because now the fluid is getting into my alveolar sacs and it's really filling up, right? This is where the butterfly appearance comes from. The spine is the area, the other part, and then use your imagination. Whee, little butterfly, right? So spine and then patchy appearance here and here. So that's what they say when they have like the bat wing or butterfly appearance. Because look at what's not being encompassed right now. The upper lungs. I don't have that patchy appearance in the upper lungs. Can you? Sure. But a lot of times it's not. Why? Gravity. It needs to be more severe, right? So that's why it ends up having this bat wing or butterfly wing appearance, but that's your patchy alveolar edema. Here's cephalization. The best way I can teach you or tell you to practice with cephalization is use the slides that I've given you for your normal chest x-rays. Have that up on one screen or whatever you're looking at the study. Use Radiopedia to look for cephalization and compare the two. That's the best way I can tell you because it takes practice of just looking at it. And I will tell you that, yes, cephalization can happen in many disease processes. So you're going to see other stuff on the x-ray with the cephalization. Normally I tell you, look at the whole x-ray. Look, when you're studying to try to understand how to see cephalization, just focus on the cephalization. Because if you try to look at the whole thing, right, you're going to go down a rabbit hole and it's going to get really confusing. So when you're just trying to find cephalization, use a normal chest x-ray that I've given you. Any of the ones I've given you in the first lecture would suffice. Okay? And then use Radiopedia to look at cephalization. Couple of key things with it. It's got to be on an upright film. If the patient can't be upright, I can't evaluate for cephalization, right? Because if they lay down, fluid spreads out like we talked about in block 1. So now it's not a valid finding. right? I need them standing up, so I need gravity to do its thing, so if it's there, it's true cephalization. So what you are looking at when you compare the two is you are looking at the upper third of your normal chest x-ray, not very prominent vessels, but then when I look on this one, it's not like punch you in the face stands out. But when you just kind of go back and forth and look at it, these vessels are much more prominent on the sick patient than they are on the normal patient. Know your area, right? Always in the upper 1/3. You cannot diagnose or call anything cephalization down here. Cannot. It's only for up here. So the fluid is backing up so much, there's so much pressure, that it's starting to go into those upper airways, those upper vasculature areas. Besides the cephalization, what else is going on with this patient? Okay, so I see some sternotomy wires, right? So they probably had some kind of heart surgery. I also see some staples kind of sitting right in here, right? But what other abnormality do we see on this film? Cardiomegaly. Cardiomegaly. I can't tell on this one. Remember, we were looking at compression fractures. We only looked at them from a lateral standpoint, so I don't know that answer. I do see what you're looking at. You're looking at how these are more curved in from the side, right? But I don't know that answer without actually getting dedicated spine images and looking at that lateral side. What's this? Gastric bubble. Is that normal? Why isn't it really on my normal? Why is it more prominent? I don't know. Maybe they just ate really fast, right? I say that to let you know, like, it's okay for it to be different and a little bit more prominent than the other one. As long as it's under the diaphragm, which we'll talk about later, and when it's not, it's normal. As long as it's under the diaphragm, it's normal. How many don't see the cephalization? To be honest, if you don't see it. We're going to look at some more. Use radiopedia. It's hard to see, right? That's why I say pull that normal up and then kind of do it side by side. Yeah?
So what's up with cephalization compared to the normal, the aortic not just like 1.9, is that part of it as well?
So it's not part of the cephalization. Good eye. We haven't quite gotten into that stuff yet. But what he's noticing is when I look at my normal, my aortic knob is more projected on my abnormal than my normal. Does everybody see that? Right? So that is an abnormality. That is an enlarged aortic knob. We haven't touched on it. Remember how I told you, congestive heart failure patients, usually there's other stuff going on that's causing it. My guess is based off of this patient, based off of the sternotomy wires, and based off of the staples, they probably had some kind of long-standing hypertension causing heart enlargement and issues to the heart, probably ended up having an MI or something along those lines. They had to go in, do a surgery to fix it, or primarily maybe a dissection or an aneurysm, and they had to go in and fix it. And so this is what it was prior to the surgery due to the comorbidity that probably led to the CHF. So you can see a lot goes on in just the picture. So again, read the question, read the answers, know what I'm asking for before you dive deep into these things, because you can go down a rabbit hole on chest x-rays and then you get to the answers, you're like, I just wasted 6 minutes reading this thing, and that's not, he just wanted to know where the heck curly B lines were. So please read what I'm asking for before you get into reading the film. Here's some non-cardiogenic causes of pulmonary edema. I know by now you guys don't need me to talk a lot about the FY slides because I think a lot of you just delete them from your slide decks. But it's there for those who want it, so moving on. Okay. This is important for your clinic. This is important for you to file away. There's a couple of slides in here like the first one that I just want you to file away. Why? Because what did I say? Congestive heart failure is an end-stage disease. Anything can be causing it. This is your cheat sheet in clinic to figure out if you need to be searching down cardiac causes or non-cardiac causes based off of what you're seeing on x-ray and primarily when you learn about this pulmonary and capillary blood pressure. Is it foolproof? No, it's not. But it'll give you an idea to where you turn around and go, okay, based off of this stuff, I'm going to chase this rabbit hole because it's really hard to chase both at the same time. You got to prioritize one over the other. And so that's what I want you to use this for. When you get out to your phase 2s, when you get to your clinic, use this as one of your cheat sheets. All right. Don't look at the notes for those of you who have this PowerPoint. We'll do this and then go on a break. What's Bravo? Parabronchial cuffing. Do we see it? Right? This is a really sick patient. Yes, I recognize probably definitely underexposed, right? I can't see my spine in between my heart, but I like this one because it really shows all those other abnormalities well, right? So parabronchial cuffing right there. Even with all this fluid, that bronchial stands out because it's surrounded. Good. What's echo? Right? Caused by pleural effusion. So we have bluntly of that angle. So bluntly of the angle is the finding, pleural effusion is the cause. Alpha? Cephalization, upper 1/3, right? It's the one we're really talking about, the upper 1/3. Do you compare this to a normal chest x-ray, then you see what I'm talking about there. Delta. It's kind of a trick. Because I said it was maybe like in the lower 1/3, but I couldn't really find them down there, so there's a curly B line there. And then Charlie is that fluid in the fissure. See that white line that kind of comes across almost obliquely right here? A little bit thicker than all the other ones, traces right to the edge of the thorax. That's fluid in one of those fissures because how many lobes do we have in the right lung? Right, so last one we looked at had this fissure. This one is this fissure here. Last one we looked at was there. This one's right here. So there's fluid in the fissure right there. Lots of different abnormalities on just this one film. There's your curly B lines again. We're going to want to break it in just a second so I get to these blue ones. Here's your Cardi B lines. That was for a class like a year ago. They kept calling them Cardi B lines. So I was like, this is fun. There she is. All right. Parabronchial cuffing, right? All right. Fluid in the fissure. Bluntly of the angle is caused by what? Pleural effusions. All right. Take 10. Come back. The airplane meal thing out there. Like everybody's coming in with my little tinfoil covered thing without cooking the break. It's cute? Okay. So you guys have an overseas flight. Look at your little like morning breakfast meal this morning. Alright. So I asked some questions about cephalization over the break. I know that I saved it until later, but I'm going to show you now. So another way to really point out this cephalization, right? Instead of comparing the normal to the abnormal, if you want, if this behooves you, I usually do it in a later lecture, but I'll show you now, is use the x-ray against itself. So look at the normal real quick. See how much vasculature I have down here, and you notice how as I go up, as I go superiorly, it tends to get darker as I go up, right? Use your imagination as you're looking at it. It gets darker as you go up because I have less vasculature. It's there, it's just not visible. Okay, so normal, a little bit brighter, darker as it goes up in the lung tissue. On your cephalization, the density is pretty much the same throughout. It doesn't get darker as you go up. That's another way for you to kind of be like, hey, is that cephalization? Well, do I get darker as I go up, or is it kind of the same level of grayness? If it's the same level, that's your cephalization. So it's another kind of a quick way to just, when you get just this image, you're like, well, I know the jerk's not going to give me a normal next to the abnormal on the test. So use that to kind of see if the cephalization is there or not. All right. Okay. Hypertensive cardiovascular disease. Lots of different reasons can cause it. Not going to get into the pathophys behind it, except for some of the abnormalities. Okay? Primary hypertension, 80 to 90%. Most common cause of hypertension. Primary means it's hypertension due to the heart. Secondary hypertension, 5 to 10%, much lower. That's one of those hypertensions where like the heart's not causing the issues. Usually it's like a kidney issue because the kidney regulates your blood pressure quite a bit. So maybe there's having some chronic kidney disease. Maybe they're on a medication that's affecting the kidneys. There's other types of stuff too, but it's much rarer. And usually you'll see it like in your younger folks, your 18 to 40, because you don't have a whole lot of 18 to 40-year-olds walking around with hypertension. You have some, but not a whole lot. This is usually a lifetime of bad decisions has now led to hypertension. But look at my symptoms. Nothing. Great. Right? Asymptomatic. Quite common. Chest pain, shortness of breath, dyspnea, exertion, orthopnea. All the things that we already kind of talked about. But what are we going to see on imaging? Some of you started to kind of saw that in the last one. You may start to see some uncoiling of the aorta. More prominent in the ascending and descending. We'll take a look at kind of what that looks like, right? If it's far gone, you're going to see some left ventricular hypertrophy, enlargement of the left ventricle. So to break that down just a little bit, why is that happening? The heart is a muscle. Just like every other muscle in our body, when it works hard, it gets larger. Because the body says, I need more tissue to do this. That's great for every muscle in our body, except for our heart. The heart gets larger, the heart actually becomes more inefficient, right? So then it's got to work even harder, and then it gets even bigger, and then it becomes even weaker, and it's this vicious cycle. So we'll get that left ventricular hypertrophy from that long-standing hypertension. This does not happen with hypertension for the past 6 months. This does not happen with untreated hypertension over the past year. This is your long-standing untreated hypertension. If you can catch the hypertension early, treat the patient, keep the blood pressure low, they won't end up with the left ventricular hypertrophy. A lot of times this is an incidental finding on either an x-ray or an EKG on a patient that comes in with chest pain because they've had hypertension for years and they don't even know that they have it, and they've been dealing with it, and you find left ventricular hypertrophy. And we'll see what that looks like on x-ray. You'll learn the EKG next semester. And shocker, it can lead to congestive heart failure and all the imaging signs associated. Right? So, 90% is the essential hypertension. That's your chronic elevated blood pressure. This is that left ventricular hypertrophy. So, let's start with the x-ray. Do we see the enlarged heart? Do we see the cardiomegaly? Okay. More than 50% than the thorax width. Can't really see the right atrium that well here. We'll explain why in a little bit. It's kind of right here, but like where does it end? It's actually right there. Is the right atrium kind of poking out? Right atrium is kind of poking out right there and coming down. We'll talk about this in a minute. But then my left ventricle comes all the way out here. So that is more than 50% width of the thorax. Okay? So as we talked about, when the muscle decompensates, the heart increases in size. The muscle initially enlarges inward, right? And so that's why this is such a vicious cycle. The heart doesn't grow out at first, it grows in, which means the left ventricle gets smaller, which means it's filling with less blood per heartbeat. So now it has to work harder to get the body its oxygen demands that it needs. And then it keeps growing in, and then out, and the ventricle gets smaller, and so it works harder, and that's where that vicious cycle is. And sometimes, I've had the most success in clinic explaining this to the patients of like why they need to take pain medication, and why it's important to have a low sodium diet, and why they gotta get their blood pressure down. Because they're like, I feel fine. Why do I gotta cut out the foods that I like? Why do I gotta, like, I don't gotta take the med. The medication makes me pee a lot. I don't wanna take it. Okay, great. Well, break this down for them in a quick, like 30-second clip of that vicious cycle, and it may actually change their mind, because the odds are if you do that, they probably haven't had a provider that's actually broken down what hypertension is and what it does to their heart and why it's important. And so if you paint that picture, you might all of a sudden buy compliance from them and go get on the medication. Because they don't realize what's happening. Look at how thick this left ventricle wall is on the CT. Right? We saw a few CTs last block of the heart kind of scrolling through. We didn't really dive too much into it, but we saw, but none of them had this thick ventricular wall. Right? This is with contrast, that's how I know. This is the chamber, this is the wall. This is irreversible. Once this happens, we can't fix it. Right? All we can do is prevent further damage, prevent further hypertrophy. Right? And that's another thing for your patients. They'll be like, hey, I can't. Once you get to the stage, like there is no like, oh, now I'm going to take it seriously. Let me do this. It's too late. Like the heart is already weaker. So that's kind of what happens with the long-standing hypertensive cardiovascular disorder. What then, later on, after that, we get aorta uncoiling. And this is what part of this is over here and this. This is your descending aorta, so you got your aortic knob. And then this large tube you're coming down here, this is your descending aorta uncoiling. This here is the ascending aorta starting to uncoil as well. Now in most of the images, here's your ascending, comes up descending. Most of the images, if we saw the ascending aorta, it was like just like a little kind of blob right there, and really we saw the aortic root and kind of came down. This is what happens after long-standing hypertension. That aorta starts to uncoil, starts to get widened, starts to get thick. Aneurysms is the word we're looking for that we start seeing. Why? Because of long-standing pressure, right? Constant pressure. The heart's having to work harder, squeeze harder, and so that pressure on the aorta starts to uncoil it, make it wider, make the lumen larger, and we start to see it on X-ray. There we see that there, compared to the normal, which we will look right here. So here's my normal. Okay, don't pay attention to this one just yet. That's a different finding. But I want you to look at the normal, look at the right atrium right here. Just get a little bit of the ascending there. Look at my heart, look at how it should be. There's my little right atrium, a little bit of the ascending, maybe kind of right there. But then when I go back, now look at this one. When you compare the two of what it looks like when that aorta starts to uncoil. Another thing we can start to see is that prominent pulmonary vasculature. Okay? First of all, I got some cardiomegaly. Definitely more than 50% of the width of the thorax. And the blue arrows are kind of hiding it, right? But you're looking at more prominent vasculature sitting over here and over here, right at the top of the arrow. So when I compare it to the side, I almost got kind of this little bit. I can see the vasculature, but it's not as prominent as it is here, kind of tracing the right atrium down here and kind of up, as opposed to, I still see some lung tissue and it's dark in here. So it's kind of tracing the right atrium here, tracing a little bit there, but then when I go over here, it's not nearly as bright white. I find the pulmonary vasculature enlargement a little bit harder to see than the left ventricular hypertrophy or the aorta uncoiling, okay? So just know where that area is. So that way, if it was something of like what, common abnormality is in this region here, and one of the choices is enlarged pulmonary vasculature, because you know the vasculature is there, and you have a hypertensive patient, that would be good to kind of pull out. But this is really, going back to this one, the uncoiling of the aorta and the left ventricular hypertrophy. Those are going to be your two big things of that long-standing hypertensive cardiovascular disorder. And I want you to take a look at this. What don't I have on this image yet? I don't have parabronchial cuffing. I maybe don't have my cephalization yet. I also don't have a patient who has progressed to the point of having that paroxysmal nocturnal dyspnea. Right? It can lead there, but we're not there yet. They're coming in with a little bit of shortness of breath, dyspnea on exertion, maybe some orthopnea, but not that paroxysmal nocturnal one. They're not talking about pillows, raising the, the head of the bed, or sleeping in a recliner. Sleep in a recliner, oh, get in trouble at home? No, I just can't sleep in the bed, right? Questions on that? Okay. Pulmonary arterial hypertension. Now this is different from your regular hypertension. This is specifically hypertension in the pulmonary artery. Okay? Asymptomatic's not on here. But the biggest thing is idiopathic familial, but Emphysema and mitral valve stenosis. These are your two things that are going to lead you down to the path of, hey, maybe they might have pulmonary arterial hypertension if they have these comorbidities. Because most of the time, when it's not idiopathic, and I can't really test you on idiopathic, because idiopathic means we don't know why, right? So if we want to know why would I suspect that a patient doing this, I have a patient with emphysema or mitral valve stenosis, I should be thinking, could it be pulmonary arterial hypertension? Okay? Commonly, they're going to have dyspnea, shocker, fatigue, maybe syncope or pre-syncope, but it's still pretty low, chest pain, palpitations, same for everything else. X-rays my initial study. Okay? CT scan with contrast is my study of choice. And you're going to see why. The CT scan is almost diagnostic. Right? So study of choice, another word for that a lot of times is my definitive study. I use study of choice when I need to know, and I want to know, and I know that this will tell me. CT with contrast. When we're looking for the X-ray, we're going to see what this pruning is, where the central vasculature is greater than the peripheral. We're going to look at it, but ultimately, when you suspect it, CT with contrast is what's going to give you the information. What happens? Why is this important, right? So, here's a picture of the heart. We know the normal pulmonary arterial pressure is about 15 millimeters of mercury, okay? Primary pulmonary hypertension, leading cause of death, is right-sided heart failure. Right-sided heart failure. Okay? Right-sided heart failure, is that a heart problem or a lung problem? It's probably a lung problem first. Lung problem first. Okay? Because we have a couple of things going on here. So look at so emphysema, lung problem, explains that part, right? Why does mitral valve stenosis, do you think that could lead to pulmonary arterial hypertension? Well, if my mitral valve is stenosed or clogging up the flow of things, everything backs up from there, right? Which means it's harder for my pulmonary veins to be dropping as much blood as they need to because it's backing up. So that if you follow it all the way back, we're going back into the pulmonary arteries, which is what's causing it, and that's where the hypertension is being caused. Regular cardiovascular hypertension is measured in the aorta, which is why the aorta is what's uncoiling in your regular hypertensive cardiovascular disease, right? That's being measured at the aorta. Your pulmonary arterial hypertension is being measured at the pulmonary artery, okay? And if we trace that all the way back from that mitral valve stenosis going back, it's stopping the blood flow, but the pulmonary artery is still trying to squeeze, still trying to push all of that blood through the system, but it's just backing up. And that's where the pulmonary artery is causing the squeezing. So that's why we usually say it's a lung problem. It could be mitral valve stenosis when we look at lungs first, right? Lungs first, because this is pushing out to the lungs. So if the lungs are backed up like emphysema, then it's going to cause hypertension, but then this would be the cardiac version of that. Here's what it looks like primarily on X-ray and CT. You notice on my normal X-ray here, I don't have sharp demarcations, right? I got my vasculature, it kind of flows out. It starts off, a little bit thicker because that's where the big vessels are, and then it kind of flows out down here towards the end, and I can kind of follow all that stuff out there. When I look here, I have a sharp kind of what we call pruning. I have my vessels, and then it's just like a line. That's it. The vessels kind of stop. That's your X-ray stuff, your pruning. But more importantly, what I want you to focus on is the CT. Here's my aorta. Here's my pulmonary artery. And we talked about that last week of hey, this is going to be really important to look at this picture and know what the pulmonary artery is versus the aorta. Yes, I have an aorta down here, right? But this is also because it's before the arch, right? So there's two aortas, the ascending and the descending. If your pulmonary artery is wider than your aorta, that's pulmonary arterial hypertension. That pulmonary artery should not be wider than the diameter of your aorta. That's why this is the study of choice. with contrast, not without contrast, because if I don't put the contrast in there, I can't make out which one is which. So you have somebody who comes in with a history of emphysema, right? Maybe mitral valve stenosis, really emphysema probably, dyspnea, fatigue. Get an x-ray with some pruning potentially, right? And you're like, I don't really know. What's your study of choice? Should we think of pulmonary arterial hypertension? You want to get a CT with contrast. Or if you have this picture, that would be enough with the patient to be able to diagnose this condition. Because that pulmonary artery is wider than the aorta. Just the only one we're going to talk about that measures the width of the pulmonary artery versus the aorta. I haven't talked about the red arrow yet. There's a reason behind that. I will come back to it. Okay. Now let's talk about briefly mitral stenosis. Yes, it can be a cause of pulmonary arterial hypertension. Increased left atrial pressure due to these things. Decreased cardiac output. I don't need you to focus on which one is left ventricular, which one is right ventricular failure. That is not for me. That is just information for you guys. I don't care as far as the radiology course goes. What I do care about is the fact that on the x-ray for mitral stenosis specifically, not the pulmonary arterial hypertension, but the mitral stenosis, you can have left atrial enlargement. That is something, based off of the anatomy you've looked at, that can stand out on an image, is the left atrial enlargement, okay? Yes, you can have right ventricular enlargement, but can I, if I wanted to look at that, what type of image would I need? Lateral, good. So if I give you a PHS x-ray, and one of the choices is right ventricular enlargement, that can't possibly be the choice, because we can't see the right ventricle on a PHS x-ray. So it's not a lateral there. Use your context clues. Again, I still don't like a test till like a week beforehand, so I don't know. These are just things over the years, that year and a half that I've seen. Mitral valve calcification, sometimes, biggest thing on this one, pulmonary arterial hypertension, study of choice, CT with contrast. Yes, pulmonary arterial hypertension can be caused by mitral valve stenosis. But if you're truly trying to evaluate mitral valve stenosis, you need an echocardiogram. An echocardiogram is that special ultrasound of the heart, right, that looks at the valves opening and closing and watching them to see how well they're working, how well the blood is pumping through the heart. So your echocardiogram is your study of choice when you're concerned about mitral stenosis. Dyspnea, infusion, apnea, paroxysmal nocturnal dyspnea, well, crap. But I told you don't worry about those symptoms. You guys are learning about JVD, right? That's part of that process. When you see these patients, they're pretty sick. So, what are the common symptoms of left heart failure? Dyspnea, tertiary orthopnea, paroxysmal nocturnal dyspnea. Great. This is breaking down and explaining the process of the mitral stenosis, right? You get obstruction of the blood from the atrium, which means you're symptomatic. Left atrial pressure builds up, left atrium enlarges. Then we end up with pulmonary venous resistance, kind of what we were briefly talking about. Then we end up with pulmonary venous hypertension, which then is going to back up even more and cause pulmonary arterial hypertension. It's a continued pathway. It continues to back up, which is why the mitral stenosis causes left atrial enlargement, because that's the primary area of the pressure. Yes, it will eventually get to pulmonary venous hypertension and pulmonary arterial hypertension, but not before it enlarges that left atrium. That's that first part that does that. Then you'll get cephalization. Then you'll get CHF. Then you end up potentially with heart failure. Venous pressure increases, arterial hypertension develops, right-sided heart failure. Okay. There's a lot going on in this x-ray. And this is where I tell you, hey, I got mitral stenosis as the concern, right? But I'm starting to see some of these CHF things. How the heck are you going to distinguish what you distinguish between? What am I asking you? Right? I didn't ask you anything yet, but like on the test, what am I asking you? Am I asking you to identify the abnormality in the yellow circles? If so, your answer is cephalization. Am I asking you to diagnose between CHF and mitral stenosis? I don't know that I can have you do that. Right? Unless the patient has a murmur. Then I might be thinking mitral stenosis because stenotic valves lead to murmurs. Right? But am I asking you to pinpoint what abnormalities are on the arrows? Let me make sure I say it right because I move things around all the time. So, what's that? A rubber band? What's my other sign that this may be something that was placed there intentionally? Sternotomy wires. Sternotomy wires. This patient had surgery. I don't think I have the notes what it was, but it's supposed to be there because I have the sternotomy wires. Let me take a look and see if I put in there what it was exactly. Yeah, I did not. But that's your first hint that it's normal because I'm like, hey, I have sternotomy wires. So cardiac surgeon went in there, did something for them in the past. It gives me a cardiomegaly here. This is my right atrium that's enlarged. Right atrium. The red arrow is actually that pruning. So this is one that started with mitral valve stenosis, enlarged my left atrium in the yellow arrow, right? Remember, aortic knob, pulmonary vasculature, left atrium, left ventricle, enlarged my left atrium, led to pulmonary venous hypertension, led to pulmonary arterial hypertension, which gave me the pruning. Oh, look, and now we're in CHF and cephalization. Holy cow. If you guys spend time trying to read this entire image on the exam, you are going to run out of time. Read what I'm asking you. The odds are it's a lot simpler than what the x-ray is. As far as like, I'm just looking for one particular thing, not asking you to diagnose this entire x-ray. If you understand the causes, the pathophys, and what kinds of things we can see on x-ray, you'll be able to distinguish between the disorders. And a lot of times, it might not even be diagnosis. It might just be, what are the yellow circles? Sir? So pruning is happening right in here. Yeah, this whole red arrow is pointing out to the pruning. Because again, see how my vasculature kind of fades away? Right? Kind of like a San Antonio Expressway, it kind of fades away into the side streets. And this one just ends here. So that's what the red arrow is showing. The right atrium ends right about here, and then the pruning is all right along this whole line here. This is the right atrium. This is the left atrium. This bulge right here, yes. Yellow arrow is left atrium and then left ventricle. You kind of see the little bump. So yes, that is left atrial enlargement. So we talked about mitral stenosis. Now we're going to talk about aortic stenosis. Okay? Long asymptomatic period. And then what happens because of aortic stenosis? What do we have? We have left ventricular outflow obstruction. Now we have the other valve that is causing the issues. Mitral stenosis because of where it sits, left atrial enlargement. Aortic stenosis because of where it sits, going back to the heart picture. Right? So aortic valve, left ventricle enlargement. So if you think of the valve and where the stenosis is, and you think about what's just before it, you'll realize what ends up getting bigger when there's a problem with it. Right? That immediate area of pressure. So you end up with left ventricular hypertrophy, the wall thickening, all the stuff we already kind of talked about. You get that diastolic dysfunction. Why diastolic? We talked about it. It grows in first, so your left ventricle is smaller. So when it relaxes, it can't fill as well as it's supposed to. So So you end up with a diastolic dysfunction because it's not relaxing as much as it should because there's extra tissue and muscle there, right? So it's not relaxing. Increased oxygen demand because the heart has to work harder. It still needs the same amount of oxygen, so it's increasing the demand. And you end up potentially with hypotension and syncope in response to exercise. Why? The heart can't keep up with the oxygen demands of the body, right? Because the left ventricle's gotten larger, it's not pumping well enough. In mild to moderate stenosis, guys, these patients aren't coming in. They're not coming in because it's not affecting them yet. Severe obstruction will end up causing dyspnea. Starts off with just dyspnea on exertion, and then it turns into dyspnea at rest. Used to be only when I exercise, now when I'm just sitting around on the couch, I'm having a hard time breathing. You notice I'm having a hard time breathing. Yes, you can have all these other things, syncope, angina, oh look, congestive heart failure. Afterwards, right? So, dyspnea on exertion, then progressing to dyspnea at rest. Chest x-rays, your initial study. Why are we doing that? We know we can't see the valves, but what if it's something else? What if it's not the valves? What if it's not aortic stenosis? What if it's not mitral stenosis and it's something else? So the x-ray is meant to evaluate the symptoms of dyspnea, syncope, and chest pain because there are a lot of things that can cause that. And if I just jump straight to the echo and I don't get a chest x-ray, I might miss something. I might miss the actual cause because what do you do when that echo? You're not getting it today. You're sending them out. They got to get it. Meanwhile, they're walking around for 2 to 4 weeks waiting for that echo when you may have actually found what was wrong with them if you had just gotten the chest x-ray. So that's why the chest x-ray is the initial study, even for aortic or mitral valve stenosis, because what if it's something else? Echo is still your study of choice. Okay? Findings are unreliable on the chest x-ray, so we're going to cover it, but if you really have aortic stenosis, you're going to need that echo. New murmur associated with a new symptom. Murmur is underlined and bolded. If you have a new murmur with a new symptom, you should be thinking aortic stenosis until proven otherwise. Star, highlight, underline. Patient presentation. So then if you have that patient presentation, along with an x-ray with a left ventricular hypertrophy, that would be enough to think, hey, I'm most likely potentially concerned about aortic stenosis. Could hypertensive cardiovascular disorder be the cause? Sure. But because I have a new murmur with a new symptom, aortic stenosis now becomes more likely than just my standard hypertension, because I have a patient presentation that tells me that. Okay. Chest pain, syncope, symptoms related to heart failure, right? The biggest thing in younger males, we have a congenital bicuspid valve issue. Rheumatic heart disease is another common thing that can cause aortic stenosis. It's not necessarily that common anymore, but it used to be. If you actually get a CT, you may see some calcifications on the valve, which can be predictive of disease and mortality, but it doesn't necessarily mean. It just means you got to keep an eye on it. Just because they have calcification on the valve doesn't mean that there's anything more you need to do. You just got to keep an eye on it, and just if they end up with hypertension or whatever, evaluate them more urgently. What part of the anatomy is there? What's the big blue arrow? Ascending aorta. You notice how my descending aorta is not uncoiling yet. This is not long-standing hypertensive cardiovascular disorder. You notice how I don't have an enlarged left ventricle yet, but I have an enlarged ascending aorta. Mix that in with a new murmur, a new symptom of dyspnea or chest pain. I'm thinking aortic stenosis. Study of choice, echocardiogram. So now you're starting to see, and you'll see as you go through it more, right, with these things that look a lot similar and kind of pull together, what are the little pieces that help point you in certain directions? right? Between this one and hypertension, the murmur and the no murmur, that's the first thing. But on top of that, I only have enlargement of my ascending aorta, not both, and no left ventricular hypertrophy yet. You can still have left ventricular hypertrophy for this condition as well. It just so happens that we haven't gotten to that stage yet. When I go into my pulmonary arterial hypertension, mitral valve stenosis, still a thing, but now it's my left atrium that's enlarged, not my left ventricle. Right? Potentially due to the mitral valve stenosis, potentially due to something like emphysema or really COPD in general, because that covers kind of all the chronic obstructive pulmonary disorders, which we'll talk about in a later block. And that's what will lead towards that. I have no cephalization. I have no parabronchial cuffing. But all these things can lead to CHF and can eventually lead to those symptoms if we don't correct it and get it fixed, right? Everything relates one another. What process am I in? What stage am I in? What's going on? Cardiomyopathies. This is all you need to know about restrictive. It's genetic. There you go. We'll get into that later. But for this course, dilated versus hypertrophic. Okay? Dilated versus hypertrophic. Look at the most common form and causes of dilated cardiomyopathy. You're going to hear me say this a lot in this block. America. Right? Coronary heart disease, heart attack, high blood pressure, diabetes. Your patient population, outside of those who are going to an active duty clinic and taking care of the soldiers in their young, healthy days. Alcohol, thyroid disease, viral hepatitis. Holy cow. So, which means if I have dilated cardiomyopathy as a concern, it's not on here, it's not an always type thing, but most likely, what's the age of my patient? Older though, right? I mean, I say older, and I say this with a grain of salt, right? But like at least 40 plus, right? Unless I give you like a 33-year-old with coronary arteries, prior MI, and like long-standing hypertension, which is possible, right? But if they're not having all of those diseases and symptoms, then this is probably going to be a later in life thing, the dilated cardiomyopathy. Versus your hypertrophic cardiomyopathy, think young athlete. Any of y'all who were an athlete when you were in high school, stuff like that, you got your physicals. I don't know if you remember this or not, but sometimes the doctor would have you like listening to the heart, and they'd have you kind of like squat down or bear down while they were doing it. They were trying to listen for a murmur and try to find hypertrophic cardiomyopathy. This is the thing that's when it's missed. You read those stories about the super healthy teenagers at basketball practice, and they're just out there doing drills, and all of a sudden they just drop dead on the court. And there is no like symptoms leading up to it. They just drop dead on the court. This is your hypertrophic cardiomyopathy. So if I give you a patient presentation, you're trying to decide between cardiomyopathies, and it's a young athlete, primarily late teens into their 20s, this should be on your differential. So we're going to talk about it, and you're going to see on x-ray, they look the same because it's an enlarged heart. It's a cardiomyopathy. You can't tell the difference just by imaging most of the time, right? So your patient presentation is important. So we just talked about the diseases, right? Oftentimes it mirrors CHF symptoms. Shocker, that's the end stage disease for all this stuff. Chest x-ray is your initial. You have an enlarged heart silhouette, often like, it says markedly enlarged, like we're talking huge. Echo is your study of choice for diagnosis. MRI is your most accurate. MRI is not your study of choice. Echo is your study of choice. MRI is the most accurate because MRI can determine your ejection fraction and figure out how severe this is. That's why it's your most accurate diagnosis, because there are stages of cardiomyopathies that, depending on what they are, the cardiologist is going to treat it differently. So sometimes that is needed to figure out where they're at. But your study of choice for diagnosis is an echo. That's why it's blue. X-ray initial study. Bless you. Look at my cardiomyopathy heart. It is almost touching the thorax. On top of that, I don't really have any other major abnormalities on this outside of a massive right atrium, massive left ventricle, like everything is, and it's not even just one, like the whole heart is big. Okay? And for those that are asking, yeah, there's a little bit of contrast. You can swallow down there. I don't know why. Maybe it's testing the esophagus, I have no idea. But, and so sometimes that's what this is. This could have been like a variant swallow study, which we'll talk about. And this was an incidental finding when they were trying to evaluate the esophagus by giving them contrast and drinking it and taking the x-rays. They're like, holy crap, look at your heart. Right? But this is your cardiomyopathies. So now this one, we'll break down a little bit more for the hypertrophic. Idiopathic in 50% of the patient, no known risk factors. The only way you're going to find it is on your physical exam or x-ray, obviously. But you end up having left ventricular hypertrophy without ventricular dilation. Thickening of the septum. You're not really going to see that on x-ray. Okay? But the echo will find it. The echo will find it. The echo is also going to look at that outflow obstruction. You don't need to know the numbers on that. I need you to know that a patient has dyspnea on exertion, possibly some chest pain, dizziness, lightheadedness, exertional syncope maybe, and that they are a young athlete having these symptoms and coming in to see you, and you get an x-ray like that. If they are older, if they have comorbidities, if they have hypertension, if they have coronary artery disease, if they've had a previous MI, any of that kind of stuff, then it's probably your dilated cardiomyopathy. These patients a lot of times have normal vitals. That's why it gets missed. And the person's just doing a quick sports physical. Just, yeah, listen. Kind of like you guys do in your clinicals. Like, aortic, pulmonary, and nerves, yeah, I listened to all that stuff, right? Well, when you do that in clinic with a 17-year-old and you miss something. Again, chest x-ray initial study, echo, definitive test for diagnosis. Look at the thickened left ventricle, the thickened septum. Okay? So, you can have primary or secondary, not so worried about that here, right? Caused by hypertensive cardiovascular disease. So these kids, maybe they have hypertension, maybe they don't. It's really the age of the patient. Infants, teenagers, and young adults. That's your distinguishing factor between dilated and hypertrophic. Okay. X-ray is often normal, but you can have cardiomegaly. Ultimately, if you find one of these patients, just maybe on a beta blocker. You just need to control their heart rate so they don't drop. Not know how to tell the difference between hypertrophic and dilated. This is the x-ray, right? So it's all patient presentation. Okay. Aortic aneurysm. We're almost there. Aortic aneurysm. We already kind of talked about it a little bit. It's provoked by environmental stressors, hypertension, pulmonary vascular disease, smokers, mainly because smokers, right, it weakens the walls of your vasculature, so it makes you more prone to this, especially when you mix smoking with a lot of smokers have hypertension too. So when you mix those two together, this makes this a lot more prevalent and possible. 75% of your patients are asymptomatic. 75% of your patients are asymptomatic. Why? Because the aorta doesn't have a whole lot of nerve endings in it, right? And the issue is not with the lungs. Really, it's just hypertension, which is an asymptomatic disorder for the most part anyways, so they're asymptomatic. You can have an abdominal pain or pulsatile mass, which you guys are talking about when you're like feeling for the aorta. This is what you're feeling for, the pulsatile mass from the enlarged aorta, okay? The ripping, tearing back pain, that is a sequela of the aneurysm. Aneurysms can lead to dissections. We will talk about that separately. But that's how you can tell the difference between an aneurysm and a dissection, is do they have that tearing back pain? Do they feel like something's ripping, okay? Yes, you can have syncope, aortic rupture, 20%, it's not super common, but it can happen. Biggest thing is your initial study is a chest or abdominal x-ray, all right? Why? Not because we're gonna see the aneurysm all the time, but because we need to rule out all the other stuff that could be causing the symptoms. You're noticing a trend here. I don't care what the disorder is. For the most part, unless I specifically mention it, your chest or your abdomen x-ray is your initial study. You may not be able to diagnose the condition, but you need to get it to make sure you don't miss something else. To diagnose this, I need a CT. With or without contrast? I'm asking you. With. Why with? I'm looking at the vessel. I'm looking at the aorta. Right? I want to see the difference. I want to see how bad it is. And especially if I think it's a dissection, I really need that contrast. And we'll see why when we look at those images. We do this even if they're asymptomatic, standard screening stuff. Men 65 to 75 years old, history of tobacco use, over 100 cigarettes in a lifetime, we need to screen. Women, it's inconclusive, but if you're going to screen the men, you might as well screen the women too. Right? But by law, or by recommendations, guidelines, definitely got to screen the men. This will be our last slide we'll do. We'll look at the pictures afterwards. We'll look at the pictures tomorrow. I'll briefly kind of do a cursory review of this, and then we'll jump into the photos, okay? But aneurysm is an enlargement of a vessel greater than 50% of its original size. Here's your normal size. I'm not hung up on numbers, right? Not for me. We'll save that for another one. I'm not going to, just like with the heart, right? I don't care about the numbers. It's what you understand the concept, okay? Because normal ascending aorta is 3.5 centimeters. Normal descending aorta is 3 centimeters. That's what you guys are measuring for when you're doing your physical exams, right? If it's greater than 5, that baby could rupture. So that's important for you to know just in general, like when do I got to refer them to surgery, which will be in senior semester. But you can see it on x-ray, but it's not super sensitive. CT with contrast is your study of choice. It's going to show all your abnormalities. If you're really concerned about like that thoracic aorta area, you can do what's called a transesophageal ultrasound. But that's going to be done in cardiology. You guys aren't doing that. You need very special techniques and skills to be able to do that kind of imaging. What I need you guys to know again is chest x-ray is the initial. We'll look at the pictures later tomorrow morning. But CT with contrast is your study of choice if you're truly going to evaluate for an aortic aneurysm or dissection, which we will talk about. Questions for me on that one? Okay, I will stop there. I will hang out for a few minutes. I know this was a really thick lecture. This is one of the thickest ones to kind of get us going and get your mind thought. Focused on the patient presentation differences, right? And how can you distinguish in a vignette with an image the difference? Because a lot of these look the same. And sometimes your answer or your smoking gun, so to speak, is in the patient presentation, not necessarily in the image. Okay? All right, we'll see you guys in the morning.